Now we are going to be talking about the future of preventative healthcare as we delve into the role of predictive tools, early diagnostics, and lifestyle-driven care that are focusing on prevention rather than treatment. Let's get into it with Dr. Mishal Al-Qasimi, CEO of Capital Health, Specialized Rehabilitation Hospital, Health Shield Medical Center, Dr. Omar Najim, CEO of Baynouna Gene Solutions 50 and BeeHAiveX, Arindam Haldar, CEO at Purelab, and your moderator, Shahad Mahdi, Secretary General at PHRMAG. Please, ladies and gentlemen, welcome your speakers.
Do you mind if we switch? Do you mind if we... Gentlemen, thank you so much for joining us today. We are lucky enough to have 3 different perspectives on this important topic: the healthcare providers, tech, and laboratories. So we will start with you, Dr. Mishal. What is one practical way that your hospitals is doing to move from treatment to prevention?
Thank you, Shahad, and thanks everyone for having me. I'm really honored to be among such a distinguished panel. When it comes to prevention, I want to really just go back and tie it up to something Pure Health Group CEO Shahad said in her statement when she said longevity has been there since the beginning of time. Prevention has been as a concept since Hippocrates. He's been quoted, or close to quotation, saying preventing a disease is better than curing it. The quotation may not be 100%, so don't go to your ChatGPT and go on that. But it is a concept that's been there since the beginning of medicine. Now, as time went on, what we have developed, what's considered today modern medicine, came in the late 18th, 19th century. And the reason it was reactive, what did you think people really suffered mostly at that time? Infectious disease was the biggest issue. And so it was reactive, as you could imagine. When you get an infectious disease, it's very reactive. It's not something that you think about prevention. And so from the 19th century, the whole healthcare system structure has been built on this reactive approach. And we've done a great job on it, right? We could measure it. We have a process to code it, CPT, DRGs, etc. And we know how to price it. And so this system just then evolved and continued to grow. In the 1960s, 1970s, there was a shift of thinking for one reason. The infectious disease started to go down. What started to come up? Lifestyle diseases, or what we call metabolic diseases, diabetes, hypertension, things that is related to lifestyle. It is only at that time that really people started to seriously consider prevention. And so what I'm trying to get to is that to really go from reactive proactive, we have to remember that it is an entire ecosystem. It's not the provider. Actually, the biggest impact on this is the policymaker and the reimbursement mechanism. And I'm sorry I may take too long. I'll give one example of proactive care. Cigarette smoking. Did you know what was the first concept to decrease smoking? What was the idea? Put labels. People read them, cared less. So somebody come with another idea, said put photographs that make people scared. Didn't make a difference. Do you know what made a difference? Taxation. So it was taxed for every 10%, 5% drop of utilization among adults, 6 to 8% among young kids. And so what I'm trying to say is that it's very critical that we think about payment and we think about reimbursement when we talk about that. Now, what we are trying to do today with the current system is a great thing. We are trying to push this preventive into it. But again, you have to remember the infrastructure was not built for that. So some things we utilize, obviously, screening. So now we know this came into about, and it's really effective for certain age, for certain gender, for example, breast mammography, colonoscopy, PSA for men. So these are some of the things we try to do proactively. The other thing proactively is obviously BMI. With a weight being at a certain weight, automatically the patient gets to be screened for metabolic diseases. So these are some of the things we have incorporated as providers, but there's a lot of work that needs to be done, and I'm sorry for the long answer.
Thank you, Dr. Mishal, for your holistic answer. But now as we hone in on the patient, what changes in patient behaviors or clinical workflow do you think have the biggest effect on ownership of allowing patients to take ownership of their health?
Great, and this question kind of almost supports what I say in the first statement. I think the biggest one has come out of the DOH. If you all guys have Sahati app, so any patients who has any lab tests at our facilities, and we are a fully private hospitals, but it goes into Sahati. Now, when we used to go after our physicians to say, please review the labs, please call back the patients if the labs is normal or abnormal. They need to know. Now the patients are calling because when they open their app, they could see if there's a red or no red. So if there's a red, they get very anxious and they immediately take action. And so you empowered the patients with, so we're lucky because now we are leveraging technology to give us that. I think the second one that we did internally is also to move from reactive appointment making to a proactive appointment making with the WhatsApp. A lot of people actually don't like calling. I'm one of them for appointment. First of all, you may think of trying to make an appointment at a different time. Could be the call center is closed. Or at a time you're very lazy and you don't want to actually talk. So the fact that you could just go on without talking to a human being and pick and select the time of preference to the specialty you need, I think those two are major. But again, I think 80% is Sahati. I think it made a lot of patient ownership, patients to have that ability to say, I control what I'm seeing, and definitely what we have created as an organization for proactive appointment has been, these are kind of the two things. But definitely DOH had a huge role in that.
Thank you, Doctor. I think you touched base on technology extensively, which leads us to our next section with Dr. Omar. You spoke about how technology reshapes human potential. What is one predictive or preventative innovation today that you believe will most transform outcomes for the next decade?
Thank you for having me. I do want my drums. Where are my drums? So I think just building up on what's been said before, technology, by the way, doesn't need to be complicated and complex. Sometimes it's the smallest of technologies that can go a long way in improving people's lives. I think the most common technology, probably more than 50% of the room, by the look of it, use it, is something called the glasses. It's been around. This is a performance-enhancing device that's been around in its current shape for the last 100 years. And it improved a lot of people's lives. Just imagine that people didn't have this technology 200 years ago. What happened to them when they can't read? They get out of society. They lose a lot of the potential they can have on the society around them, or they cannot see far. They get overcome by enemy coming to their village to invade. So these technologies do happen. However, my anticipation that the biggest impact of technology will have, or a single technology, is without sounding like somebody, oh, again, I know what he's going to say. It is AI, by the way. It is AI with the impact that it will have on so many different things. Today, AI is one of the three things that enabling us to change not only people's health, people's economy, people's society, but also their potential, their existence as a human. I think with the AI, it's not too far in the future, in 10, 20, 30 years' time, we will be a different species. So today we are Homo sapien, and I think many of you read that book. With the enhancement of technology, of chips being put in us, of enhancing our bloods in a way to allow us to perform better, we'll be a different species that is enabled to be a different species with AI. So today we are generating huge amount of data, which is great. We generated part of it about 50 years ago, but we couldn't do anything with it because also today we have computational power that is available, cheap, accessible. And three, we have the great brains of people who are doing the algorithms and do the data science and data crunching. All of this is leading to a huge advancement in healthcare. So today, about only what we do is about 40% is evidence-based, 55% is inherited from 100 years ago and 200 years ago, from Mendel, from Dickens, from the days whatever. And you don't go far with it. Now with AI, this is going to be changing hugely. Within the next 10 years, 20 years, we'll be catching up very quickly on enhancing human longevity.
That's very exciting.
And I'll
Dr.
be
Omar.
very quick for the next one. I know. I'm feeling guilty already.
That's very exciting, Dr. Omar. So we know that genomics is your bread and butter. As genomics and deep phenotyping becomes more mainstream, what is the single most important step healthcare systems can take to integrate those insights, not only responsibly, but equitably?
So equitably is the key word. So today, over the last 100 years, by the way, the average age of humans is about 40 years. Today it's about 84. We doubled it within 100 years of our existence on Earth. Our existence probably, depending on what you read, it goes back to about 20, 30,000 years back. Within the last 100 years, we improved our age expectancy to about 84, doubling it. Part of it, many advancements, Mishal talked about it, but the one that will get us to get to 100, as indicated and stated as a goal or Northern Star by Pure Health, within the next 20 years, I think it's genomic. Yes, we talked about AI, but genomics. Genomics is enabling us to understand not only the disease causation element of our genotype, but also enable us to come to a way where we enhance the performance of the cellular level of our tissues, of our organs, and us as a human. So it will continue to be happening. AI, again, is going to enable it. But inequality, we have to bear in mind that it needs to be to a level where the science is shared and the cost is low to allow everybody to access it. Today, we talk about life expectancy of 84 years old, but this is not equal. So 85, 86 in European countries. In sub-Saharan Africa, it's 60. Yes, they came a long way than everybody else. In the last 10 years, they added about 10 years to the life expectancy, but still inequality exists. Inequality exists today in our society. We are considered as affluent society. Inequality related to gender inequality. So the average age for female is less than males. There are genetic factors to it, but still, it needs to be catching up. There are inequality related to socioeconomic inequality related to education level. So understanding the label that Dr. Mishal is talking about, it's an understanding, it's an educational level element that will enable us to do that. But I'm very positive that it will be happening.
Thank you, Dr. Omar. So as we now have heard from two perspectives, we'll shift gears to the laboratory perspective. Arindam.
I think you should have 5 minutes. 4.
There you go.
Take it.
What needs to change to shift the focus from treatment to prevention?
Shahad, that's a $1 million question. First of all, thank you for having me here, and good afternoon to all of you. So I think 2 things, and I'll keep it focused. One is we need to rethink and realign our financial incentives. And I know Dr. Mishal touched upon it, because our healthcare system was designed primarily influenced by the Western setup, done at a time when life expectancy pretty much equated with our working life. Infectious disease were the main killers, not NCDs, not that 1 in 9 globally, 1 in 5 people in UAE have diabetes. So the focus has to change, and I think the next decade has to be about the 3 Ps, prevention, prediction, and partnership. So right across the regulator, the payer, the provider, and the patient, we need to rethink how the financial incentives is. We have a perverse fact, and I'm sure all of you will believe, and agree as well. For a healthcare provider, it is more lucrative to treat a stage 4 cancer patient than taking care of a stage 1 cancer patient and making sure he or she doesn't go to stage 4. So that's how warped our current financial incentives are. So that needs to be rethought. Second thing is that we need to really scale up preventive thinking, and that can be really done today with the latest, the version 4, the generative AIs and the large language models. We can actually integrate data from the wearables to the EMR, to the genomics data, the imaging data, clinical history. where we can honestly personalize all three parts. So say, for example, for the insurer, we can have sophisticated algorithm that can do underwriting better, so the premiums can be done effectively different from each one of you. We as patients or as consumers can have premiums which is based on how healthy our lifestyles are. And more healthy lifestyles we lead, it can automatically reduce our premium. And from the provider angle, we really need to get into value-based care, where patient is at the center, where ideally the best doctor visit should be the one that never happened.
Absolutely.
The best treatment should be that one that was never needed. So that's the future that we honestly have to get into.
Absolutely. So doctor, how is Purelab using preventative analytics and other laboratory technologies to step into prevention?
Sure. I mean, one can obviously keep talking about it. I'll just take through the maybe journey of life. So, and I'll talk 5 or 6 things probably. We in our genetics center do for expectant mother NIPT, which is between 8 and 10th month of pregnancy, which talks about what kind of possible defects like Down syndromes and other may happen in the unborn baby, so that action can be taken beforehand. We are very proud to run the federal newborn screening center of the country in Abu Dhabi. More than 45,000 infants have been tested. It's within the first 5 days of birth, where we look at various preventable metabolic, genetic, disorders that may be there in the baby. More known is obviously our preventive check, the various blood, checkups that we do. We have done some of them for self-pay patient at really accessible rates, because we don't want insurance to be a barrier for someone who really wants to be healthy and wants to get him or her checked. Then, of course, the real predictive thing comes with genetics, right? I mean, we started our genetics center last year. The next 12 to 18 months looks really promising. And we will be getting, I mean, obviously we are doing targeted gene sequencing, whole genome sequencing, NIPT I spoke about. We'll be getting into pharmacogenomics, gut microbiome by end of next year. So that's the true prediction or predictor of longevity. So honestly, a large part of our focus, and you heard Shaista yesterday as well, that we want to democratize longevity. That's our North Star. So there's a whole lot of work that is going on. Very exciting indeed.
Thank you. Gentlemen, I know we're running out of time, but if in one word you could describe the perfect healthcare ecosystem that prioritizes prevention, what would that word be? Dr. Mishal.
Oh, that's a tough question for one word, and I'm a man of many words. But I think, Lud, what he said, it doesn't exist, so we have to admit that, and I think that's fair. And I think it's taken into that where the regulatory arm, policy making, reimbursement, and the providers really share the table and share the pie of responsibility equally. So I think if you want to look at some models in the Finland and Sweden, it's there, but still, I don't think it exists.
Thank you. Dr. Omar.
Personalized and precise. I think it need to be.
Amazing.
And honestly, we are already very lucky to be in a country where leadership is already thinking preventive in a large way. Just to build on whatever we have said earlier, probably under the blessings of the leadership, if there can be an empowered committee, including the regulator, insurer, provider, where we honestly rethink the overall incentive model, where we are incentivized to keep people healthy. That should work.
Amazing. So it sounds, what I heard is collaboration is key to reaching this goal together. Lucky we have 3 different perspectives here. The perfect example of collaboration. Would you like that?
I was going to say that, but we have to put in account it's a J curve. I mean, one of the issues that people don't talk about, for preventive care, it's a 20-year investment. Government budget and everybody's budget is 5 years, so that's also something that you have to look into, because typically you will spend today, you don't see the saving only in 20 years line, which is a generation shift. And that needs a lot of stuff to take into account to truly move into proactive care from where we are today.
Absolutely.
Absolutely.
But this is the right place to do it.
Absolutely.
And, I think there isn't any other country that will say this is our plan for the next 50 years.
I agree.
So I think we take that plan at the country level and translate into what health is going to look like.
Amazing.
No, and finally it will help, because it's a fact that tertiary quaternary care is more expensive than primary care. Absolutely. So if you invest more in the early part of the value chain, overall health exchequer budgets will come down over time.
Thank you so much, gentlemen. It was a pleasure, and thank you guys for tuning in.
Thank you, Shahad.
Absolutely.